Welcome to the Oral Apothecary Podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories, but keep it edgy yet light-hearted.
Guests share their career-defining drug, song and book, and also share their joyful patient stories. Welcome to the Oral Apothecary Podcast. My name is Jamie Hayes. For this episode, we're joined by Dr. Berwyn Owen. Berwyn is a pharmacy proprietor and a practicing prescribing pharmacist in North Wales. We'll welcome Berwyn in a moment as he shares a drug for our formulary, his career anthem, and recommends a book for the Oral Apothecary Library. We've got a micro discussion for you too, informed by a report from the Berwyn Commission, the Foundations for the Future Model of Health and Care in Wales. We'll have a gentle pub-style chat with Berwyn and his views on the future for community pharmacy. But first, let me welcome my two fellow apothecaries. STC is in Nepal and so won't be joining us. So Gimmo is in Cardiff and Claire is in Newbury. Welcome both.
Evening.
Welcome back, Claire, the fourth apothecary.
Thank you very much. Lovely to be here. Great to stand in for STC.
Yeah.
So while you've been in the Far East, haven't you, Jamie? Steve's out east. I've been in the Far West, so I've been in Swansea all week with the Berwyn Commission, and so doing that this week. Last night I sat next to Nairi Berwyn. So she is the great-granddaughter of an Iron Berwyn. So that was quite a nice chat to have to her and hear her views on how the NHS is going.
Very good. What have you been up to, Claire? I've seen your name and face splashed over social media this week.
Yeah, it's been a really, really busy couple of weeks. So the polypharmacy juggernaut continues to deliver on masterclasses, polypharmacy action learning sets. But last Tuesday we launched the RCGP RPS repeat prescribing tool. So I've been leading that work for the last year and a bit. Enormous challenge, bringing lots of different views around how we can support general practice to improve the kind of consistency around repeat prescribing. So yeah, glad that sort of landed. And then this week I've done a frailty course with the Leeds teaching frailty unit. So that was really interesting. Lots and lots to think about. Knew lots of it, but yeah, really helpful to just focus on all of that. And of course, Wigan run the Super League Grand Final, so I'm a happy girl, yeah.
Frailty and falls, that's what I've been talking about the last couple of weeks. And yeah, I think we're going to pick up on the repeat prescriber in a future episode, aren't we, Jamie?
That's the plan. It might feature a little bit today, but yeah, we've got an oral apothecary analyses lined up for that.
So how about you then, Jamie? Come on, where have you been?
I've got a long list, actually, because STC's away. Look, I'm going to go for a long list. So first of all, I'm going to give a shout out to the fifth apothecary, because he's gone rogue and is the host of a new podcast from Prescript.
I thought he was dead to us.
Talking Meds. If you enjoy listening to this one over the last couple of years, then you will enjoy listening to Jonathan and his guests too. You'll recognise many of the guests, so top guests and some top content. So that's the Prescript Talking Meds podcast. So please give it a listen. It's great stuff. I think the episode 2 has just come out with Lucy
Pollock on it, and it's brilliant.
And Magnus Hurd was his first guest, and they were talking about some old favourites, NSAIDs and some of the asthma stuff. Then last couple of weeks ago, I had the pleasure of chairing the Prescript annual events and awards. A great day. Hearing from the Prescript award winners and the keynote speakers, one of which was our fourth apothecary. So I think, Claire, it's the first time I've had the pleasure of introducing you to the stage, I think, and it's the first time I've heard you speak on the subject that I know you're an expert on, and it was brilliant. So I was really impressed by the content and your delivery. I thought it was fantastic.
Oh, bless you. Yeah, I've not been to the Prescript annual event before, so it was great. A trip in the rain to Nottingham, and then fantastic to hear about some of the great projects. And interesting as well to have the Scotland team there to be able to kind of think about the work they've been doing on polypharmacy in Scotland. Yeah, it was good.
And so the way that you weave in the theoretical and then the emotional element of it, I thought you did a brilliant job. So yeah, and then look, I've just returned from Singapore. So I've chaired sessions and introduced colleagues from India, Thailand and Singapore. That was the 33rd Singapore Pharmacy Congress, another excellent conference. And then look, on my return, what was waiting for me on the doormat was my copy of Rebalancing Medicine.
Oh, I got mine as well. Thank you, Neil.
By apothecary alumni Professor Neil Mascray. There is 5-star reviews on Amazon, essential reading for all healthcare professionals and anyone considering being a patient, I would suggest. And then final news from me. Look, you can tell Steve's away. Look, we can get away with anything. Top 10s for us, Gimmo. Top 10s in the UK, Finland and Singapore.
Excellent. UK as well, is it?
Yeah.
What, is that the health charts?
It's medical charts, yeah.
Wow.
Apple medical charts. So let's move on. Our great pleasure to welcome Dr. Berwyn Owen. Berwyn is a former Chief Pharmacist at Betsy Cadwaladr University Health Board in North Wales. He's a former council member at the General Pharmaceutical Council. He's on various pharmacy leadership things and is the independent expert member on the UK Pharmacy Professional Leadership Advisory Board. He's the past Programme Director for Medicines Management. I'll stop there, Berwyn. Your bio will be in the show notes. Welcome to the podcast.
Thank you, Jamie. Thank you, Paul and Claire, for the invitation.
Well, let's get back to that invitation, Berwyn, because there's some podcast trivia here. So when we started the podcast, Gimmo, who did we have lined up as our first guest?
It was Mr. Owen, wasn't it, I think?
Well, Dr. Owen.
Dr. Owen, yeah.
It was.
We were sitting there in the Milk and Sugar Cafe, weren't we?
Yeah.
Trying to think, who do we know who'd be entertaining?
Yeah.
Interesting. So no pressure.
And so Claire, our fourth apothecary, is looking shocked now.
I thought I was the first guest and the first choice to be your first guest after my "it's a bit blokey" comment.
Indeed.
So I had no idea I was only the second choice. It's a whole different thing now.
Yeah. Now, do you know what, Claire? I was checking my phone. I was thinking, how? And so Berwyn didn't respond to a text, really. He didn't respond to the text when we said, "Are you up for this?" And it went a bit quiet. But I have to say, and look, he's on the call, I'm so glad, Claire, that we went with you, because after your "it's a bit blokey" comment, and then the education you gave us in that first episode that has stuck with us through every episode, I think, and every live show we've done, it's worked out well. So it's a pleasure to have you on, Berwyn, finally.
Thank you, Jamie.
What have you been up to?
I think the problem at the time was when you sent that text was I didn't even know what a podcast was.
But is that? I was trying to dig into my memory, Berwyn, because we go a long way back. What was you were doing Berwyn Our Pills or something like that as well?
I was.
What was that?
That was in just the turn of the millennium, because I returned back to North Wales, relocated from Newcastle upon Tyne in Northumberland. Mum had taken poorly, came home and decided to relocate back home and be closer to them both, which was the best decision ever, really. So I dropped into Glenclwyd Hospital at the time and had met the late Jerry Wilson, the Chief Pharmacist there, at a guild conference many years earlier. And he said, if ever you're back on the A55 of North Wales, drop in which I did, and met up with him in Newtown. And they gave me a temporary role for 6 months to be a pharmacist on a programme of work that Welsh Government had commissioned on an individual patient record. And that was, 24 years ago. But they cut the funding on it 18 months in.
Very good. So you're back in Wales and now you're back in community pharmacy.
Yeah, it's been a couple of years, and it was, I guess I do tend to have a 5-year cycle when, and it's naturally, isn't it? And it's good to have those 5-year cycles where you reflect and you get a sense of what direction you want to go next. And as you know, Jamie, I'd left Wales in the mid-80s. I left straight from school, didn't do my A-levels, and embarked on it was an advertisement in the Daily Mirror, I think, or one of those daily papers that used to come to our house, and it was an advert for a research assistant with Beecham Pharmaceuticals, as it was then. And I applied and I got the job, and so relocated to Worthing in Sussex. And I remember the guy who actually gave me the job, and he was a pharmacist. He's an industrial pharmacist, and he'd done a PhD and so forth. And he just said to me, "There's a really good degree program that you could really follow, and if you work hard and you're dedicated, then pharmacy opens up a lot of avenues for you." And one of the things that I remember him saying was, if you do pharmacy, it will allow you to choose wherever you want to live. And that was a real desire, because I then realized actually if I wanted to work in community pharmacy or in hospital pharmacy, to a lesser extent industrial pharmacy, but actually you could go anywhere, within reason to live. And that was a real desire. And the second thing he said was, you'll always have a trump card in your back pocket, which is community pharmacy. So you can go off and do other things, but actually there'll always be a calling and there'll be a role within the community. And so having spent, as you know, Jamie, many, many years then, I went to do my degree in Brighton after doing my BTEC program, then followed by a doctorate up in Newcastle in pediatric medicine, and then returned to Wales, worked in hospital, did a similar thing to yourself and became a prescribing advisor over in Gwynedd when you were over in Conwy in Denbighshire. And for some unknown reason, you end up in these roles, don't you? And people, there are opportunities that arise. Some of them are to do with changes that happen, system changes, so reorganizations and so forth. And so my role became a little bit of a test bed, if you like, where they made an integrated chief pharmacist of both 2 county LHBs and the local trust in Bangor. So I remember having 3 NHS emails to respond to 3 different organizations before the advent of the integrated structures that came into place in 2000, when was it, 10, 11? And so, and then I remember having got my first chief pharmacist role in 2006. Relatively young, isn't it, to be in that kind of role? And you kind of think, will I do this for the rest of my career? And I think when the pandemic happened, that's when the real change. I think I'd started to think about other opportunities prior to the pandemic, but obviously the pandemic was needs must, and it was a call on us all to arms. And after that, then the opportunity came when probably one of the nearest pharmacies to my home came up for sale. The proprietor phoned me up and said he was relocating to Northern Ireland, and the opportunity came to buy a pharmacy at the age of just shy of 55.
So it's a case of you liked it so much you bought it.
I think it's one of those things when you think it's a successful, really, it's a rural successful pharmacy that has been in the family for 3 generations, and so for 70 years they've had that pharmacy in their family. And it was really humbling to be asked by the family, because both the parents and Lle, the previous owner, who's since located to Armagh, to be asked, would you want to buy this? And we don't want to sell it to anybody. And I had connections with that area because Dad was from there, from the Nantlle Vale. And, and it was one of those dark winter nights in February when the phone call comes and you just think, God, that's a bit left field. And then you kind of ponder on it and you reflect on it. And then I thought, okay, maybe this is worth, a different direction. And that's what happened. So it took me maybe 2 or 3 months to think it through. And then I never envisaged the complexity that goes with becoming a proprietor of a community pharmacy. My word.
I'm itching to come in and ask, just please describe that after the career that you've had, that because I had the complete opposite. I started in community pharmacy and felt I'd sort of learned what I needed to know and never had any desire to be a proprietor. Please just describe what that has been like.
I think moving from what became a very macro role at a strategic level within the largest health board within Wales, and certainly one of the largest in the UK. And I guess what the calling was, Claire, was part of it was I'd become fatigued with Teams calls and Zooms, ironically, and working from my desk in this attic. And I thought there must be more to, if you're quite an organic person, you need that human interaction, don't you? And that was a real pull and draw. But certainly moving into the complexity of community pharmacy, and if I say in England, of course, we saw the converse, where there was a lot of instability. And in Wales, thankfully, the Welsh government had stabilised, if it's the right word, community pharmacy contractually. So at least we knew that before the advent of pharmacy first in England, there was, for a good number of years, and real beacons in Wales who became, I guess, my mentors, if you like. So Dylan in Llanidloes, Llyr and his team in the Llyn, who's now, I think, just purchased his 7th pharmacy up here in northwest Wales, and many others down the south. And it was just that, and it was really the excitement of going into what was this new role, which the new prescription really advocates, which is you become, in effect, what you've learned in hospital pharmacy and other parts of pharmacy is that you become a clinician practitioner within a community pharmacy setting, as opposed to, what was the historical model.
And that's what I was going to touch on. So, because where me and Jamie had this, we'll get Berwyn back on, was at the Royal Pharmaceutical Society conference when you presented as the future of pharmacy, which made us all laugh. Because we've all known you for 20 years, and there's the future of pharmacy coming up on stage.
That was from one of our alumni as well, wasn't it? Chris Martin was chairing the day, and he came up with his, who'd have thought Berwyn Owen is could be the future of community pharmacy.
But I think the interest, but anyway, the interest, it is, I mean, this has got to be almost unique, hasn't it? As someone who's been primary care advisor, chief pharmacist, sort of, I know you've been involved in some of the sort of pioneering work to develop the role of pharmacy and medicines management, and suddenly you've got the opportunity to put that into practice in a real life setting. It's almost like you've been given I know it's not a game because it's your livelihood, but you've been given the chance to put it into practice. So how are you finding that?
It's rewarding, Paul, very rewarding, and I guess I've done a good honest day's work for the first time in my life. So some people say, is what you put into it, you get out, don't you? And it's what you put in, and you get the real sense of reward from seeing what difference the team achieves within that community. So it's a rural community, and the pharmacy covers a significant expanse of rurality and also a very deprived area. So we've got probably one of the least car ownership percentages as per population within certainly northwest Wales. Lots of people really have got major issues around access to healthcare, and they refer to me not by name. That you must be doing something right, because people come to the door and go, "Is that bloke in today? So is he in?" And it's and these guys are farmers. They're young children with their parents. They're women. They're young girls, and the elderly. And Claire was mentioning around in discussion earlier on frailty, and it's just that the sheer scope of what we're trying to respond to, I guess, as a team. And I'm working alongside, what I've been really lucky and fortunate in is that David Roberts, who obviously worked for the majority of his career with Boots and Rowlands, he's with me alongside me, and I've also now got Roland, who's a pharmacist who's just newly qualified, and we're on a shared program where he does half his time at Bangor Hospital and half his time with us in Penygroes Pharmacy in the Nantlle Valley. And so we're in this shared program, and HGRW are supporting that as well with formalized study leave and so forth. So I guess prescribing became, I think, the key enabler, doing the IP program. And I did that. So I stayed in the health board as a chief pharmacist in my final year, and I, with the agreement of the executive, I decided to do the prescribing course, but I did it in practice in the out of hours, not far from where Jamie used to work, up in in Colwyn Bay. And the GP I worked with was Pepe. He's a Spaniard. He's from Santiago de Compostela, and he's a fantastic character and wonderful mentor. And so he, I guess, gave me some really good insight into managing acute illness in the out-of-hour setting, which then has translated really effectively into a community pharmacy setting.
It's so important. I'm really struck by what you said about the kind of health inequalities and how, you know, in England, it frustrates me enormously. We've got all these programmes trying to address health inequalities, but the one bit of estate in the NHS that's already in the parts you want to reach is community pharmacy, and it always has been. And I understand that Adam Todd has just repeated that great paper that he wrote looking at where community pharmacy was in England and the fact it bucks the inverse care law. And it's just so critical. And I think for the decision makers in the NHS, we need people to really understand that really important part of the state, and the fact that Wales have been able to kind of support it, seen it's important, support it, give it long-term planning and a strategy, and look what you're able to do to groups of people who wouldn't be reached by those services otherwise. It's incredible. Hats off to you. I might pay you a visit.
I'd love you to, Claire. It's I mean, it's long hours, isn't it? But then again, everybody's role is long hours. It's just that you're on your feet, maybe.
It's the feet bit, yeah.
Exactly. The actual pharmacy itself is, as I said, it's been in the same location. It used to be an old butcher's, and it's it was became a pharmacy 70 years ago, and it's just sadly, although it's quaint and it's lovely and it's very traditional, the original shelving is there that was installed by David's grandfather as a, so the carpentry and everything else is just fantastic. But unfortunately, it's because of the demand that's now coming through the door, we're not able to meet that demand with what we've got. So an opportunity has come up to buy a funeral parlour run by the cooperative, which shut a year ago, and it's colossal compared to what we've got. It's 260 square meters, and it's big. And so the sale's gone through, and the work is just about to start now to hopefully move that into an era where, again, you're reinvesting. And that's what I've done, I guess, is that I don't really want to run away with being labelled as a community pharmacy who's profiteering. And I want to just reinvest what we're making back into the business and actually providing something better for that community in the long term.
The Oral Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
Let me stop you there then, Berwyn. There's a few things I should mention at this point, that this isn't a pharmacy podcast. So we have to mention that, don't we? Even though we have a community pharmacist on at the moment. So it's not a pharmacy podcast. But also, in the second half, we'll come on to some of your plans that you've got with purchasing the funeral parlour and your plans for it. Okay, so we'll come back to that in a moment. Look, I need to do this now. STC says something like, look, one of the privileges of coming on the Oral Apothecary is you get to share with us your 3 choices, Berwyn. So the first one we're going to ask for is your desert island drug for our formulary, a medicine that you may have an emotional connection with. What, have you given this some consideration for us?
Yeah.
What was in the mix?
Well, the mix was, I remember many, many moons ago being in Cardiff, actually we were in one of the Indian restaurants in Roath, the one, in Cardiff, in Roath Park, where it used to be...
The Jew Barrage.
That's it. It used to be a toilet, and it was converted into a restaurant.
We're getting into the detail now, but yes.
Basically, I remember going there once with a guy called Craig Curry, who is phenomenal at data. I met Craig a couple of weeks ago. He's good friends with Jonathan Underhill. There we go. And Craig said to me at the time, I'm doing some meta-analysis at the moment on and this is, you got to remember, this is a good 10, 12, 15 years ago now. And he said he was looking at some meta-analysis, and he said, I've got some really interesting data on metformin and on health outcomes and on its properties, which lay beyond just diabetes, he says. Yeah. And so I read a bit more about metformin and followed its story. Yeah. And of course, even now, it's been in the press, isn't it, in the last week, 2 weeks, that it's got potential benefits for aging process and so forth. However, so that was one, Jamie.
I've said it before and I'll say it again. Stormin metformin.
Indeed, yeah. And I guess the one which I come back to, which is probably the one that I feel is most poignant to me personally, is the one that I did spent good 5 years of my life doing my doctorate up in Newcastle. An opportunity came up, and I had no ambition to do a PhD, none whatsoever. It was just that the project that was being proposed is what drew my attention, and it was a collaborative between Sunderland Poly, as it was then, the RVI, the Royal Victoria Infirmary in Newcastle, and then my own background, having worked in industry, being able to draw in various sites that I could then collaborate with to bring the technology to scale up the production of cysteamine hydrochloride. And for those of you who may not be aware, so cysteamine hydrochloride is used extensively in the chemical industry in order to be, it's part of the synthesis for a number of drugs, namely paracetamol. And as a compound, those of you who have worked in hospital environments will remember it as being acetylcysteine is a similar compound as an antidote for paracetamol poisoning. But cysteamine hydrochloride was found to be, in the 70s, 80s, when it was discovered, to subsequently have benefits for lysosomal storage, metabolic diseases. And there's one disease in particular called cystinosis, which is the inability to metabolize cysteine. And this leads to really dreadful effects on the newborn and the child, where they have failure to thrive and they have end-stage kidney failure by the age of 10. And cysteamine converts cysteine to lysine, and therefore the child can then metabolize it. And indeed, if they can ingest it and tolerate it, then they thrive. Unfortunately, it's a sulfur-based compound, and as soon as the child ingested cysteamine, they vomited. And they were called stinky poos and all kinds of things, and a lot of social issues in relation to the drug. And so I basically embarked on formulating the compound, the actual the actual chemical into a medicine by enteric coating. So spheronizing it into pellets and then enteric coating it in a delayed release format, and thankfully it worked. And the ability at the time was that you had the ability to do studies based on what was called at the time doctors and dentists exemption certificates. So you were based in a tertiary hospital in the RVI Newcastle in the early 90s, and basically I was in the lab 1 minute, I was going into the factory another day and scaling up, and then by the following day it was actually being taken by the child. Yeah. And we could then monitor the bioavailability and the bioequivalence and so forth of that compound. And it became successful, and we spread that drug then nationally within the UK.
So for Steve's spreadsheet, just what was it called again?
Cysteamine hydrochloride.
Okay.
And then still around, Berwyn?
Yeah, what happened then was this actually becomes quite an extraordinary story.
Make it quick, Berwyn.
So yeah, I will do. 25, 30 years hence, I get a call. And I get a call from an American legal firm who basically were asking me to consider becoming an expert witness. And I had no idea what had gone on. And basically what it was is that part of my presentations and publications had been shared whilst I was doing lectures over in the States in the mid to late 90s. And actually a team in the University of San Diego, California, utilized my thesis and formulated their formulation, and then subsequently marketed it, patented it, and sold it to various pharmaceutical companies. So it's now available, Paul, in other parts of internationally by the name of Proskippy, and at what, as you can imagine, orphan drug price costs upwards of £250,000 to £300,000 per patient.
Oh, blimey.
Yeah, so it's and though for what as a consequence we have internationally is that some countries clearly can't afford access to that medicine as a consequence.
I'm trying to think, Gimo, has anybody chosen that one before?
I don't think so. But not only that, no one has chosen a drug and give us a chemistry lesson at the same time. So that is fantastic.
Thank you, Berwyn. Okay, let's move on. Your career anthem, Berwyn.
When I relocated from Wales in '86 and made that journey with Dad and my mum down to Worthing in Sussex, and they left me and got the train home, and I got my first pay packet, and I was so homesick, and as you'll be aware, Sussex is quite flat, apart from you got the Downs, but compared to Snowdonia, it was quite a contrast. And anyway, I got my first pay packet, and as is tradition, it was the turn of my 18th birthday, and I went to Woolworths, and I bought a tape to put in my Walkman, and the tape, it was a double tape of Pavarotti, Luciano Pavarotti, greatest arias, and therefore the song which I listened to when I was walking the Downs, and ironically thinking of home, but also was Nessun Dorma, and it was None Shall Sleep, and obviously one of the most famous tenor arias in all of opera. So I grew up as a brass bandsman. I played the cornet, and I played in the village band. So classical and that kind of music and operatic had always been my preferred music. So as a youngster, I was actually quite, what could I say, a bit alternative to the tradition of what people did listen to. So yeah, None Shall Sleep, Nessun Dorma, and I guess ironically, 1990 then beckoned, and it was the Italians that hosted the World Cup, the FIFA World Cup, and
so suddenly you were fashionable, were you?
Indeed, yes, yeah, Renaissance man, you see, and what happened was obviously that Nessun Dorma was the theme, wasn't it, to the World Cup, 1990.
Very good.
Is it our first opera, Jamie?
I think so, and we should point out to the listener that it really is on Spotify.
Yes, yeah.
It really is on Spotify. So okay.
I guess, Jamie, as well, it's the story, isn't it? It's the story of actually, it's obviously sung by Calaf, the unknown prince, who falls in love at first sight with a beautiful but cold princess, Turandot. So,
yeah.
Berwyn, you and I were very different 18-year-olds.
Yeah. My imagery is of Italian footballers running towards the camera, having scored a goal and looking to the gods, I think, is... Okay, and then a book then... for your final choice, what's the book for the library, Berwyn?
This one was hard because, similar to yourself, Jamie and Paul, and Claire, no doubt, is that your library will be full of books which, I guess, in the context of what you see people reading their novels on beaches on holidays, and my books traditionally are more lifestyle books and behavioral books and psychological books and so forth. So. And I guess the one book which has stayed with me, well, there are three, I guess, Jamie, very briefly. Strengths Finder, I read, and it's a book which gives you your 5 key strengths. Yeah. And very briefly, I've advocated that book to anybody who I've mentored or coached, because it's about finding your strengths and sharpening your strengths as opposed to being too focused on your weaknesses. Yeah. I guess the second one, which I've also advocated and read many times, which did have the biggest impact, I think, on me personally, was the Chimp Paradox, Mind Management.
Okay.
Yeah.
By Steve Peters.
And it was that, and I guess it was that realization around the ability of the mind to become at times very irrational in your flight, fright, fight, tendency, and the ability you can train your mind to be rational at times when you do need to be, in those situations. And I think that was completely transformative in my behavior. And what I've done subsequently is, for example, if somebody does absolutely lose it with you, that generally you allow them 10 minutes and usually they've exhausted themselves in that time. And then you can start to engage in a rational discussion with them afterwards. And the one that I'm actually reading at the moment, which is one for you, Jamie, is How to Buy Back Your Time, unless you've read that already, by Dan Martell. And it's more of an entrepreneurial book. And the main idea of it is that for your business to continue to grow and thrive, it is business related, but it can be applied to any work related context. And it's, in order to continue to grow and thrive, at some point you have to start buying back your time. And that means that you don't hire to grow your business, you hire to buy back your time. And therefore you buy the skill set around you to release your time to do the stuff that your unique and USP is good at, to enjoy and bring the love and desire back into the work life. And that's probably the one I would choose of the three.
So that's the great considerations, Berwyn, and it's the final one, the buying back your time, obviously has a lot of resonance with some of the discussions around time needed to treat that we talk about in general practice and primary care, that there just isn't the time to do some of this stuff. And then it also links, because when I'm running the workshops, I link with failure demand, and we've got John Seddon lined up for later this series. But the whole point is, if you can identify failure demand coming into your organisation or your practice or your network, then actually that can give you time back. And so it's, and so growth isn't everything is the other thing, isn't it? People, that's a bit of a sucker punch to think that the idea is growth, and it doesn't have to be that.
It applies as well in similar but different in terms of, our staff in the NHS and in the public service spend a huge amount of time on non-added value work, isn't it? And yet we don't support them in avoiding that time. In fact, we add even more on, and that's the sort of waste of bureaucracy. So quite interesting, that book.
Very good. Okay, thanks for your choices, Berwyn. Our micro discussion next. Gimmo, over to you.
Okay, so yeah, we're not a pharmacy podcast, but we did want to talk about medicines management in the context of community pharmacy and what that might look like in the future. And so we're lucky to have the future of community pharmacy with us, so we thought it was a good opportunity. And I guess the two reports, just briefly, that we sort of thought we'd use as a basis for discussion was, one was the Berwyn Commission report, The Foundations and the Future Model of Health and Care in Wales. And so this is their latest think tank piece around creating a sustainable national health and care service in Wales. The care bit is important because obviously there's talks going on around the UK about creating the national care service as well. And so just some facts from that I thought were relevant before we have the discussion. The average age at which major illnesses will develop in people in the future is going to be 70 years when they start developing major illnesses, and more than a third of the population will have a major illness by 2040, and the years that they will be spending with ill health will increase. And so the report references the principles of prudent healthcare, which we've covered on the pod before, and a whole society approach where health and well-being is embedded throughout everything. The second one that we were linking to was the report by the Royal Pharmaceutical Society, or the strategy Pharmacy Delivering a Healthy Wales. So obviously that leans heavily into the medicines agenda. And I guess it talks about the area that we'd be most interested in is seamless pharmaceutical care. So it talks about improving access to independent prescribing, you've already mentioned that, optimising the use of medicines and minimising medication-related harm, direct referrals to and from the pharmacy, and pharmacy teams leading the management of medicines as the experts in therapeutics and medicines use and optimisation. So their vision in that paper, and it is a joint paper with the Welsh Pharmaceutical Committee, is that these will things that will be a part of normal practice by 2030. So just wondered what you thought, well, Berwyn particularly, and Claire, in terms of the context of those reports, but how it might shape the future of community pharmacy?
I think it's great to see all of this set out. I think for such a long time, particularly in England, that the lack of clarity of the direction, we keep adding things in community pharmacy, but it feels a little bit piecemeal. And I love the diagram that if you've not seen it in the Berwyn Commission report, there's this brilliant diagram that kind of summarises it all. And I think the bit for me, it starts at the top with data. We're incredibly fortunate in the way we've got access to so much data about medicines and how it relates to healthcare, and it should shape everything we do. And I think that is perhaps an ask for community pharmacy, particularly in England, is you sit on a wealth of data. What are we doing to use that to understand more about the populations that you serve? So it was really heartening for me to see that sort of right in the middle of all of that, but just so great to see it all set out as a proper strategy with community pharmacy right in the middle of all of that. I mean, I could talk for hours about what I'd love community pharmacy to be doing, particularly around my sort of favourite topic of, problematic polypharmacy and looking after older people and reviewing medicines with the lens of frailty. And I think this is the beginning of being able to describe that. And you can see in the future, particularly the way you describe, Berwyn, that the community you serve, you could be the first place people come and go, I'm in a bit of a mess with my medicines, please can you help? And then the services come on from that. Whereas at the moment in England, the SMR is supposed to be the place that starts, but it relies on the patient knowing that exists or coming forward for that. And we know that that's not quite the case when you talk to patients. So yeah, lovely to see it sort of more that way around.
Yeah, and building on the point you mentioned, Claire, around the prudent healthcare, Paul, and Claire around frailty. And I guess I'm just going to refer to this book behind me, which is That'll go under mortal medicine, isn't it?
Being mortal, yeah.
And being mortal, that's it, Jamie. And it's got a very, very, very powerful section in that book where it talks about beyond a certain number of medicines, and I think he said 5. For every one medicine you add, you increase frailty. It's directly proportional to increasing frailty, and I think. And that's what we're seeing, isn't it? Is that we're seeing practice now, most definitely with, for example, hypertension, whereby the desire to really get somebody into those targets, you're now seeing practices where we may be allowing those blood pressures to stay slightly higher because we know that it will avoid falls, for example, by not being so aggressive on some of those practices.
Yeah, I've just written an article on exactly that topic because it frightens the life out of me. Well, I completely understand and am behind big policy to get undiagnosed hypertension dealt with. But when you apply that to very older people with frailty, it becomes completely unscientific and nonsensical. And yet here we are. It's really important that the work that they've done in Newcastle has demonstrated in over 85-year-olds, for every additional medicine you add in, even when you account for things like being male, living on your own, the things we know increase your risk of mortality, regardless of what you're trying to do for that patient, there's a 3% increased risk of mortality. So we need older people to understand that us reviewing your medicines and maybe stopping some is not about money, it's not about denying you access to medicines because you're old, it's about safer care of people in their later years, because that's what the science says we should be doing.
Look, that gives me an opportunity. Claire and I were just chatting about this at the start. This is John Lorna's column from this week's BMJ, the British Medical Journal, and he's discussing the 4. He's been to a workshop on where the 4 pillars of heart failure have been presented, and he sort of concludes the way guidelines are often presented nowadays seems to confuse research with reality, conflate populations with people, and blur the boundaries between clinical education and pharmaceutical marketing. If you really want to deliver best practice for each individual patient, you may need to get off your soapbox and become curious about why so many patients end up not swallowing your guidelines and advice, or your pillars and pills. So
Perfect.
Most weeks John Lorna nails it, really.
Mm-hmm.
Yeah.
And I think the other aspect, Paul, which you were referring to in introducing the papers around the foundation from the commission, the Berwyn Commission, is, and I guess it's something which drove me into community practice from my previous role, is, and I guess this is a bit which I'm still frustrates me largely, because I've lived that life as a chief pharmaceutical officer within a health board, where the desire and the talk and the rhetoric is around care closer to home and the shift of resource from secondary care into the community. And I must admit, my own direction has really tried to drive that, if you like, and I do my utmost to try and keep people out of hospital. But it's still, certainly from the Bevan's thinking and think tank, it's still, I feel, very much on the ground that the direction remains that hospitals predominantly are sucking resources, of the public purse. And I'm seeing it even in correspondence I've had this week from some of the directors, and I'm thinking to myself, when will we understand and accept that hospitals cannot solve the solutions within their hospitals?
And that's what struck for me. So I haven't managed to do it, but if you just think about the numbers that we're talking here, if you're saying that, the population's going to age almost exponentially, those numbers, a third of those numbers are going to have chronic conditions over 70. And you think how many people are in hospital now as a result of chronic conditions such as diabetes. We're talking numbers that we almost can't imagine, like I would say 4, 5, 10 times the numbers needing to be treated. And so that's why I see the future, not just of community pharmacy, but of healthcare is how on earth are we going to manage those high numbers when what the report also says, I don't know if you noticed in there, is that it says something along the lines of, the numbers of older people will far exceed those numbers of a working age. And this isn't a long time, but it's 2040. I'll still be working in 2040. I think my retirement age is 2039, so maybe I'll just about have retired. But it's not that far away.
So we better look after ourselves, because by the time we get there, the services to actually care for us probably won't be there.
So, Berwyn, look, I stopped you just before your choices because you were just telling us about the funeral parlour. Quickly and briefly, tell us about your plans for, instead of sort of profiteering, as you said, or didn't appear to be profiteering, what do the plans look like? And because when you mentioned those at the conference the other day, they sounded great.
Yeah, so the scale of what we have, and it's really caused immense excitement in the community. So, there's an 88-year-old man that came in yesterday and he said, "Can I just tell you," he says, "you have lifted this community. Not me personally, the team, and the effort we're putting in." And he said, "You've lifted the spirit of this community. Things were flat here for a long time, but just with this approach that you take into care and your ambitions for what you're going to do across the road, with opening up a significant space whereby to attract, there'll be several obviously consultation rooms in there, and that will obviously attract then lots of people who have been in touch with me around co-locating services within that hub and creating it into more of a community style hub, which is what Paul was describing earlier.
So what have you got planned? You've got planned bigger premises, you've got consultation rooms coming in, co-locating other health services?
Yes, yeah. So we've got some both therapists, some medical practitioners, some of the local nurses, social services and others. They're keen to get involved. They're already, podiatrists, for example. I guess one of the things we're doing is we're asking patients and asking the people themselves, what is it that there's a gap at the moment in what we can provide? And so many of them came back and says, we just need local podiatry. We have to travel so far to have that kind of service. And I'm also having some conversations where we're not able to co-locate, that we can actually get those pathways working more effectively. So because of the way Welsh Government have obviously established the similar pathways with optometry, dentistry and so forth, so it enables me now, when I'm struggling with eyes or struggling with teeth and mouths, I have pathways which I can actually refer patients now on the day to those practitioners elsewhere in the nearby town. But they're talking about maybe coming along and utilizing some of that space as well. So I'm not saying that we'll have dental chairs there at this stage, but who knows? The accommodation does enable that to happen going forward. And then net zero, I've hopefully utilizing some of the technologies that are available for that as well. So the roof space, as I said, is 300 square meters. So that would accommodate an awful lot of solar input as well into the running of the service. And may I add, Jamie, I do my own personal medicines deliveries. So I don't delegate that responsibility. I choose to deliver the medicines to my patients personally. And by doing so, I can have a look at them, I can see how they are, and I can have a look around the house and go, there's maybe some hoarding or some issues going here that Claire was referring to. And I see that as a very important aspect of my role is coming out of that pharmacy and actually reaching out into those houses.
So that's huge. That's huge, that, isn't it, Berwyn?
Yeah.
That, I mean, Gimmo mentions the whole oxygen service that sort of disappeared years ago a few times, but that is huge. That's in between the text in our reports, isn't it? That's in the white space that you just don't.
And in a way, you've gone full circle. I know we're talking about the future of pharmacy, but you've gone back to some of the values and some of the things that used to be done that we never, as Jamie said, we never actually valued, isn't it? Is I always said it with oxygen. I know Jamie mentioned it. I remember some of the most impactful interventions I ever made was delivering oxygen and spotting a patient who was clearly deteriorating. And so when they outsourced that to the companies, that value-added service was completely gone.
Yeah. I'm wrapped around, because I'm fortunate in that the opportunities to work collectively with the third sector, there are 2 neighbouring social enterprises that are next door to this facility. So they are very much community-based. And so they've got an electric transportation system, a taxi service. They've got electric bikes and so forth. And they're very much doing things around the community. They're also into housing and have, as an offshoot, housing association, so that we look at accommodating people effectively in good housing in the community. So, and I guess come back to, finally, I guess from me, is that notion of tuberculosis. And I remember reading the public health information around tuberculosis when it was, the effect it had at the time on communities across our nations. And we all felt and believed that penicillin cured it, but in fact it was housing that was the biggest impact on reducing tuberculosis and the reduction in cohabitation. And I guess this is where I think working in our hub with those partners around understanding housing needs and other challenges we're seeing and witnessing is a key aspiration.
It's brilliant stuff. I can't wait to see where you kind of go with it. It's reminded me of the frailty course that I was on the other day. There was Seacroft PCN have got a proactive care service doing exactly what you've just described, going to our frailest, most vulnerable patients who sometimes live in some really, really, shameful conditions for countries where we live. Some of the pictures were really, really upsetting, and go and make some fairly simple changes to get them, good housing, warm, dry, all the rest. And you think, yeah, it does feel like we're kind of, in some ways, elements of what I heard my grandma as a district nurse talking about in the 1950s around, just giving people the basics that they needed in order to support good health. We're sort of back here, how bizarrely, in 2024.
Very good. A big thank you to Berwyn for joining us on the Oral Apothecary, for sharing his stories. I knew there'd be stories. His Desert Island Drug, his book for the Oral Apothecary Library. Coming up next time, we'll be joined by Professor John Seddon. John is a British occupational psychologist and author, specialising in change in the service industry. He's the managing director of Vanguard, a consultancy company formed in 1985, and the inventor of the Vanguard method. We look forward to welcoming John next time on the Oral Apothecary. You can contact us via Twitter at Oral Apothecary. We're on LinkedIn. You can email us at oralapothecarypod@gmail.com. Don't forget the website, www.theoralapothecary.com. Gimmo, have you got a final ingredient for us?
I have, yeah. So, Diolch Berwyn, that was great. And really, really nice to see you again. And a big thanks to Claire as well for stepping in. Your locum fee will be in the post. So we've talked on the podcast about the use of behavioural insights and nudge theory to try and change or nudge people's behaviour towards what we think is a desirable outcome. An example we often quote is the use of defaults. So, you make the default option the choice that you actually desire and introduce a bit of friction cost into choosing the alternatives. Can you remember what the biggest example of this was? Organ donation. And so the default option has been changed to opt out instead of the need to opt in, and the idea being that the friction cost of opting out would deter most people who it is assumed would be generally in favour anyway. So the theory was, if we change the default, we'll increase the rates of organ donation. Has it worked? Well, new research from the University of Bangor and reported in The Conversation has found that the introduction of opt-out organ donation laws in the UK may have actually led to a drop in donation rates. The policy shift assumed that individuals consent to organ donation unless they explicitly opt out. However, rather than increasing donations, as I said, it's fallen from 67% in 2019 to 61% in 2023. So why is this? Well, families of potential donors often still expect to have the final say, even though in law they don't. This has led to a cautious approach by medical professionals who are hesitant to override family wishes. And additionally, the complex legal sort of dynamics in the context of grieving families has made the process for clinicians much more difficult than was ever anticipated. So the research highlights the need for better education and clearer communication with families to ensure it does it. And it also talks about simplifying the process to alleviate the burden on families, etc. But I guess the lesson is there for us who use and promote behavioural science to try and improve choice architecture. It is a really delicate science, and so as in the case of organ donation, you may get the opposite result to what you desire. So perhaps the message is nudge and don't shove, and be ready for any of those unintended consequences.
You have been listening to a 3 Apothecaries production. Sound engineer Jimbo Slough, original music Jamie Brewster, artwork by David Baker and Jacob Howard.
Thanks for listening to the Oral Apothecary podcast. For maximum effect, instill weekly.
This episode of The Oral Apothecary is sponsored by jamiehayes.co.uk.